All right, welcome everyone. Thanks for joining us today for yet another in-person meeting. Although we do have our speakers remote today, so we're very glad that this hybrid approach is working pretty well for us. Even my thing is not, hang on just a second for me. I need to get my slides to be able to advance. I'd like to extend a special thank you to Sanford Burnham Previs Medical Discovery Institute for lending us their auditorium this morning. They've been very attentive to our needs and very helpful. I'd also like to introduce the Informed Prostate Cancer Support Group principals. We have Bill Lewis, who's currently setting up our after-meeting lunch. He's our president and does the wonderful newsletter summaries. We have Jean Van Vliet here in the front row, director and treasurer. Steve Pendergast, who's online, secretary and newsletter editor. We have Bill Manning in the back, director and videographer. Myself, Aaron Lamb, and John Tassi, our webmaster. And of course, there's you, well over 900 members, and everyone is a volunteer. You can be too. Hopefully, who here is here for the first time today? Could you raise your hand? We've got 3 people so far. Did each of you get a profile form as you walked in? Please do fill out the cover sheet and bring it to me at the podium or to Bill Lewis or Jean afterwards. That way we can add you to the mailing lists and make sure you're informed with everything that we can provide you. And you'll likely get a phone call within the next week to help answer any of your questions that you might have and get you the information that that would be useful to you. The welcome packet also had quite a bit of articles and booklets that can help you out. Let's do a little survey. We did see the 3 people that were here for the first time, and who has been recently diagnosed, perhaps hasn't yet decided what they're going to do. Right, we've got a few people just figuring out what the treatment is going to be for the near term. How many people have had prostate cancer for less than 1 year? All right. Again, obviously the new people. How many are 1 to 4 years? Okay, and 5 to 10? All right, quite a bit. 11 to 15? And our longer members, how long, Gene?
20 years.
20 years, and behind you?
19.
19 years. Oh, and more. 22 and 23. Okay, we got the winner here, 23. The key for doing that survey is, especially for you new people, is to realize that you have a long life still ahead of you. You know, as you saw on the first slide, prostate cancer is 2 words, it's not a sentence. And there are wonderful treatments that are probably going to be a little bit overwhelming, but there is certainly quite a variety of very good options today. Now, as we do this next survey, especially for you new people, look around and see who raises their hands who've had these different types of treatments. Those are the people that you might want to go up to during the lunch and ask them questions more about their experiences. So who is on active surveillance? Great. And how many have had surgery? Quite a few of us. How many have had radiation, including proton, X-ray, brachy? Quite a wide selection of people. How many people have been on ADT and hormone therapy? Again, a very popular treatment. How many have had chemotherapy? Is Gene's arm getting tired yet? How many have had new treatments, such as focal therapy or immunotherapies, Xofigo, Pluvicto, Provenge, quite a few as well. We have some very advanced experience in this audience today. How many people have had recurrence of their cancer? It has come back. Yes, it is something that we do have to worry about, and that's why some of the long-term people are the people that have had the prostate cancer the longest are here today. And who is decided about their future treatment? Who is undecided about their future treatment? Yes, quite a few. And thanks to Bill, we are on Instagram, and our population of followers is doubling much quicker than hopefully anyone's PSA is. We're now up to 511 as of this morning. So please do look for us on Instagram. Please follow us, click on some posts and like them. That will help get our word out to a wider audience. What is amazing is that this has also led towards to a lot more people watching our YouTube videos online. Upwards of thousands of people now watching even the more recent videos that have been posted. And we also do have a video. Oh, yeah. And our support to you comes from our website, which hopefully you've all found by now, www.ipcsg.org. We also have a channel on YouTube, which is called Prostate Cancer Support. You should also be getting at least email copies of our newsletter. Those are fabulous. Bill and Steve in particular put a lot of effort into those. They have write-ups about the previous meeting, new articles of interest, a little cartoon or two to keep a smile on your face. And of course, we have the monthly meetings on the third Saturday of every month, though not in December. We also have Jean and Bill available for hotline calls. Their numbers are there. They're also on the website. And, a lot of you starting out on your journey of determining treatment, I remember in my first days, I was absolutely, paranoid of my situation and completely confused on what I was going to do. Those are the moments where it's best to, give the hotline number a call and ask for some advice. And we do need more volunteers. We need people to suggest and recruit new speakers and to share their experience. Please do contact us on the website or by calling one of the hotline numbers to let us know what help you'd like to provide. And I'd like to remind everyone of our support group purpose. We share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants. We are not medical professionals, and any sharing by anyone of our group may not be a substitute for your medical counsel. And we do need your support. Our donation, we are a 501c3 organization, and if we could pass around the baskets for some donations today, volunteers, if you could help us out, thank you. Donations are tax deductible. We have no medical or religious affiliations. Our largest costs include the website, advertising, and mailings. We also do make some donations to appropriate prostate cancer research organizations. If you have new organizations that you know of that you think would be of interest of having our support, please do let Bill and Jean know. And you can also make a donation either today in the basket or online via PayPal, or by sending a check to the address that you see on the screen. That address is also available on the website as well. For today's meeting, we have See It, Treat It, the Telix pipeline. We have Dr. Mary Hames of Telix Pharmaceuticals. Dr. Hames, just a minute as I need to get back to my notes here. Dr. Hames has her bachelor's and master's in chemistry and an interdisciplinary PhD in biochemistry, genetics, and chemical engineering from the University of Alabama Huntsville, and is the U.S. Medical Director for Telix Pharmaceuticals. We also have Dr. Chowdhury. He has his PhD in virology, immunotherapy, and tumor targeting from University College London, and is a medical oncologist based in London, England, specializing in prostate cancer and other genitourinary cancers. They're both joining us online today. However, we also have Heather Vinci here in the audience who can provide some information about Telix and their products. She'll be available after the meeting for your questions and has some information to pass out as well. Sorry, I have these slides a little bit reversed. Let me just remind you that next month we have the upcoming meeting of the member roundtable with Phil Young, Lenny Green, and David Ferraro. And I've been told that that will include David's experience with methionine restriction using the Hoffman protocol presented to us online by Dr. Robert Hoffman last August. Now, before I turn it over to Mary, as you can see, I'm wearing a bit of a back brace today. I'm glad that I'm actually here because an hour ago I was flat on the ground in a lot of pain. So I will not be running around the room with the microphone. However, no one online is going to be able to hear your questions unless you have the microphone. So please, when it comes time for Q&A at the end, raise your hand. Mike is going to bring the microphone around to you, and then we can ask the doctors the questions. So with that, Mary, please take it away.
Great. All right, how's that look?
I think, oh yes, that is presentation mode. Yes, it looks good.
Super. Thank you all so much for joining me today. It's really a pleasure to speak with you all and share with you what we're doing here at Telix. At Telix, our tagline is here's my disclosures. We've got some clinical things to discuss, which are forward-facing. Forward-looking. So here, at Telix, our tagline is "See it, treat it," and what that means is, we have an imaging agent, we have imaging agents, but ultimately we want to treat these things. So for every modality that we have an imaging agent, and then we have a companion therapeutic. So I'm just going to walk through a few of these. So for prostate cancer, we have an imaging agent that's currently approved in the US, gallium PSMA-11. It's also approved in Australia and Canada. And it's called Illuccix. And then the companion therapeutic is 177 lutetium rospatamab, and I'll go into a little bit more detail later on that product. But that's our therapeutic that we're in phase 3. For kidney cancer, we've got an imaging agent with zirconium and a companion therapeutic with lutetium. And I have a whole bunch of slides about our kidney program that I left out because I assumed you guys wanted to hear about prostate, but if anybody has questions about kidney, we can talk about that later. So we also have some earlier phase programs in brain. So we've got a glioma program for imaging that we're looking to seek approval next year, and then we have some products in bone marrow conditioning. But I'm going to skip ahead to our imaging agent, Illuccix, or gallium PSMA-11, and then we'll get into our therapeutic. So our imaging agent is gallium PSMA-11, and it was approved late November 2021, and we launched it early next year. And indications and usage, it's a radioactive diagnostic to use with PET-CT in patients with prostate cancer. The initial indication was for patients who are at risk of metastasis, suitable for initial definitive therapy, and also patients with suspected recurrence based on elevated PSA levels. And then just this year, we had an expanded indication where this product is also now indicated for patient selection for patients for lutetium therapy. So, if you want to have one of the currently approved or our future lutetium products, you've got to have a PSMA scan prior to that. And then also, this product does guide management changes. So in up to 43% of high-risk patients at initial staging, 68% of biochemical recurrent patients, and 70% of patients with metastatic prostate cancer. And also, I just realized I've been very rude to not introduce Simon. Simon is here kindly joining us, and just wanted to make sure that y'all know that Simon's going to be jumping in to give kind of his perspective as a medical oncologist on a lot of this. So
not rude at all. Mary's one of the most polite people you could hope to meet or work with. I should say I don't have a conflict of interest slide, but one of my conflicts is working with Telix as an advisor. Mary's going to be singing lead vocals, and I'll be the backing singer, so I'll try not to sing out of tune, but we'll hopefully work well together. And thank you, Aaron, and also Stephen, who helped us with our prep earlier. And while some people may be 5 minutes late in San Diego, I seem to be 8 hours later in London, so you're all well ahead of me.
Thank you, Simon. So I just wanted to show you guys a bit of the data that supported the approval of Illuccix. So we had 2 studies that supported the approval with 2 very distinct populations. And both of these studies were completed near you guys at UCSF and UCLA. So first is the pre-RP study, which is prior to prostatectomy. So these are patients that had biopsy-proven prostate cancer and then met one of a few criteria that made the patient higher risk. And they had gallium PSMA-11 or PETMR. And these data here just show some of the performance of gallium PSMA-11. So 90% specificity, 47% sensitivity, 84% negative predictive value, and 61% positive predictive value. And just remember, sensitivity is the ability to detect something. My favorite way of describing sensitivity is like a pregnancy test. So it depends on where you are. If you have high, you'll have high sensitivity depending on how much of something is present. So if you're 2 months pregnant, you're definitely going to have a positive test because it's very sensitive when you have a certain level of hormone. And then, if you're trying to test a week prior to being pregnant, your sensitivity is not as good. So it depends on how much of something is present in your body, how high your sensitivity is. And then specificity is really showing your the likelihood that you'll see something that's not there. So like if you have a something that's going to show you that's negative. Then we had our BCR study. So this is a separate population of patients that had biochemical recurrence. So they had a serum PSA of greater than 0.2, more than 6 weeks after prostatectomy, or an increased serum PSA of 2 above nadir. And so then this is percent positivity stratified by PSA. And this is relevant in biochemical recurrent patients because you want to be able to test and see something. You want to have that high sensitivity at a low PSA range. So, at a PSA greater than 2, 91% positivity. And then when you get under 2, the percent positivity is lower, but still comparatively very high. And then a couple of slides here on detection of metastatic disease versus conventional imaging. So, I know Simon can speak to this once I get through some of this data, but basically conventional imaging is looking at bone scans. And so when you compare PSMA-11 to conventional imaging, it's significantly better. So, much greater clinical sensitivity when you're looking at accuracy of PSMA-11, 92% versus conventional imaging, 65%. Sensitivity, 85% versus 38%. Specificity, 98% versus 91%. And then the specificity is comparable, but remember your specificity is looking at, if you have a scan and it's positive, if you're doing a bone scan and you see a positive result, chances are it's real. And so that's kind of, forgive me if I'm not describing specificity in the best possible way, but But so in a bone scan, if you're positive in a bone scan, it's got a good specificity, so chances are it's there, but it has a very low sensitivity. So if you're negative on a bone scan, it doesn't necessarily mean that you don't have prostate cancer. So those are some of the differences. And then the equivocal findings higher on conventional imaging. And so when you look at diagnostic sensitivity of bone metastases compared to bone scan, diagnostic sensitivity is almost 100%, 99 to 100% with gallium PSMA 11, and it's only 87 to 89% with a bone scan. And this kind of folds into this figure, which is showing that gallium PSMA 11 reveals bone metastases in 10% of patients classified as M0 on bone scan. So the bone scan says, oh, there's no bone mets, but in fact, there are. So Simon, do you have anything to add here on, clinical implications for patients on conventional imaging versus gallium PSMA 11?
I think, first of all, well done with sensitivity specificity, which I struggle with how to explain. I'll definitely be stealing the pregnancy test analogy from you. I think it's a very nice way of explaining it. I suppose, probably looking at it slightly more simplistically, and Mary has a PhD in chemistry. My PhD was much lower value and was more about the public houses and taverns of London. But I think what I would say is that it's a step change. I'd probably maybe look at it like maybe moving from black and white to colour television. So suddenly you can see a quality of imaging that just wasn't there before. And I think bone scans, I'm surprised to see the specificity of bone scans as high as 91%. I think that's probably in the very best hands. And I think what we see on bone scan imaging in the clinic is a lot of indeterminate bone lesions. And when you ask patients about it, they'll say, particularly the boys like myself, they'll say, oh yeah, I fell out of a tree when I was 10 years old and broke my arm or something like that. And it can often be things that are uncertain. And I'm very conscious I'm speaking to an educated audience, but also an audience of patients. And I think as doctors and healthcare professionals, we underestimate how much, I say, well, we don't think it's anything, but there's this spot on your bone scan, how distressing that is for patients. And I had a friend of the family who's recently had a bone scan with this indeterminate bone lesion, and they've gone on to have a gallium PSMA PET scan, which has revealed it not to be present. And they literally said to me, as soon as I was told the PET scan was negative, the pain I was experiencing went away. The psychological impact of that is massive. So I think we mustn't underestimate it. And like any new technology, we're learning about it, and I think that's one of the exciting things here. But I think, as Mary has said, it's already provided an impact in the clinic, in the indications she talked about, and we can talk about how that's evolving. But I think it's one of those things, the imaging for prostate cancer was poor beforehand. And I think this is really important in terms of what we're able to communicate to patients, how we're able to stage the disease. And now, as Mary's going to talk about, how we're going to be able to treat the disease as well.
Thank you. Kind of following along to what Simon's saying on change in management, with this new and improved imaging, it does impact how physicians like Simon, determine what are the next steps. Because if you can't see a metastases and you don't know it's there, then you don't know to give more comprehensive treatment. So in randomized studies of patients, gallium PSMA 11 was found to influence management changes by about up to 43% of primary staging. So again, I've got two separate studies here. On the left, primary staging and biochemical recurrence, and then on the right in metastatic prostate cancer. So in initial staging, 28% of patients had a management change because of the PSMA 11 scan versus 15% of patients on a CT bone scan. And then in biochemical recurrence, 68% of patients had a change in management. And so, additional analysis of tumor classification, gallium PSMA 11 changed the tumor classification in treatment-naive patients. So 26% of patients had a change in tumor classification. So, that's staging of the tumor. And then 44% of patients had a change in their radiotherapeutic plan. And then again, in our metastatic population, even higher. So once you have metastatic disease, the relevance of where are those metastases, how many metastases do you have if it is metastatic, is incredibly relevant to know with a PSMA scan. So, your bone scans are not gonna catch things outside of the bone. So, you want to have a scan that's going to be able to tell, do I have this in lymph nodes? Do I have it in other parts of my body? And then we've got a couple of examples here. Simon.
Sorry to interrupt Mary. Mary said earlier, because I seem very rude. Mary said earlier I could.
I told him he could. Want him to, in fact.
He was a witness, and I said she would live to regret it. I think coming from that, and this is perfect timing, but actually the next image is perfect timing.
Okay.
Because I think what we're seeing is the dynamic aspects of this. I was trying to think how to explain this, and I'm going to use an American football. I say American football because soccer is how some people describe proper football, which is English football or world football. But American football, which I came to be a big fan of and got me through a very hard winter in Boston. And you're laughing in San Diego because I didn't check what the temperature was going to be like before I did my fellowship out there. And my God, it was cold in Boston. But anyway, the sports got me through, particularly the American football. And they had a new thing there that was new to me, was this spy cam, where you have the camera from above and you see the ball thrown and the timing. And it makes it such a beautiful sport, seeing that position from above. And I think the dynamic of PET scans we're just starting to see. Now, because of the limitations of presentation, we're seeing fixed images here. And but I think what we're going to see evolving is the dynamic and the timing of imaging. And as Mary says, the number of images is going to be really important, and also the dynamism, how they change, and also how they change with therapy. Bone scans, perversely, actually look at bone turnover rather than cancer activity. So what we see sometimes with bone scans is we see a very good response for the patient symptomatically, say bone pain may get better, their PSA may drop dramatically, but their bone scan actually gets worse and flares. And that's really complicated. It's complicated in the trials, and it's awful for the patients and their relatives. They come in and they're like, what's my bone scan saying? You have to say, well, it looks a lot worse, but we think it's so and so and so and so. And I think that's really tough for patients. So I think the dynamism of PET scans will also change how we do things. Sorry, Mary, if I didn't quite fit with the talk as it's going.
No, that's great. So I'm just going to give you some background on this patient. This is a patient case at an initial staging patient. He had a prostate biopsy. He had a Gleason score of 9 and a PSA of 22.9. And I'm just going to ask Simon to walk us through these images and tell us what you're finding here on metastases.
So I feel rather thrown in the deep end as not a radiologist, but I think what we can see here, so basically PET scans provide the color to the black and white. So I think what we're seeing here the pelvic lymph node metastases, and you can't really see these on the soil. I'm using a pointer that you can't see, but if you look at Mary's now highlighting, thank you, Mary, that was perfect time. So you can see at the back of that's perfect there. So you can see these lymph node metastases here. They're tiny, but they're relevant, because they may aid if this is a localized patient, and we're going to look and see their bones next. But this is a patient who may well have had an extended surgical option with regards to that. This is important knowledge in terms of the staging and in terms of therapy. So the patient may have gone on to have a surgery that wouldn't have necessarily taken out those lymph nodes, or radiotherapy that wouldn't have encompassed them. So that would have been a localized case. Now on the second panel across, we can see here, so sorry, I should have said, these are cross-sectional images. Apparently, I've jumped a little bit in the deep end. And these cross-sectional images that you may or may not have seen before, you may have seen them on yourself, but essentially we're taking a slice across the patient, and we're looking from the toes upwards. And bone appears whiter, more sclerotic, as we sort of say, and you can see sort of the white bone, hopefully. Apologies, I'm not explaining this particularly well. And the soft tissue appears sort of grey. And if we go to the middle panel, you can see, that Mary's highlighting there, a lesion at the top of the femur, the long bone of the leg, and you can just see that subtle image there, which just isn't present in the panel above. And I think what with regards to PET is, even for a non-radiologist, and maybe this is a good thing, we can see that that's pretty obvious. And therefore, I think one of the things we see, and actually one of my friends, Tyler Siebert, who is in San Diego, and you may be one of your doctors, a really super guy. He's just published on radiotherapy from around the world and looking at how the expertise that he has in San Diego and his research department, strangely and not really surprisingly, isn't displayed in radiotherapy across the world, with many people missing the target lesion. So I think this type of imaging, which provides a really stark image and a really, I think, an easy image to interpret even for a non-radiologist, will help with that, will help with therapy, interpretation, will help make the grey less grey, to be honest. And I think that's going to be helpful for all of us as we have treatment in different centres, different expertise, I think is important. And I think that just highlights the lymph node metastases. Mm-hmm. Here's another couple of images. We see the CT scan. Again, this is a cross-sectional image looking from the feet upwards, so taken across the body. You can see on the CT scan, I'm looking to see on the CT scan if that's obvious. It isn't obvious to me, that lesion there in the vertebrae. So the cervical vertebrae sort of sit in your neck, and this is one from 1 to 8, and this is the 7th vertebrae. But you can see there on the PET scan, that is pretty obvious. I don't think it's obvious on the CT scan. I'm looking now to see if it's a bit moth-eaten, but to me that looks pretty intact, that bony lesion. It's not even more sclerotic or more white, which we often see with prostate cancer. So I think Mary's chosen that image well because it really highlights the benefit of the PET scan. Also, if you're thinking about a radiologist looking through, the radiologist won't just look at one image, they'll look at hundreds of images per patient. And if radiologists typically work in dark rooms in basements of hospitals fueled by coffee. And you walk in there and they're looking at lots of images, and the number of images people are having to report is going up. So I think there is user variability, and I think this just makes it a lot easier for people to see. And also then you can see on that response, you can see white. So sorry, I should have said at the start, PET scans go for like a heat map, from blue to white hot. It's a great example of white hot, so a very PSMA active lesion. And I think that activity, avidity, will also correlate with prognosis and may well also correlate with how with things therapeutically. But reassuring for patients and for us to see that white heat go away. Here you can see an interesting image. What we're seeing at the top of the image is the bowel. So the loops. If we look at that, thank you very much, Mary. Perfect time. So this is the bowel, and that lights up as hot with this particular tracer. So you can see the bowel is hot. That isn't cancerous. That's just how the radioactive dye is excreted. But then you can see in the left part of the pelvis, what's called the iliac wing. You can see. So if we go down just a bit further down the other side, Mary, keep going down. Sorry, this is really the other side. The other side. Go there. Exactly. So you can see there a pretty subtle lesion. You can see it on the CT scan, which is interesting that you couldn't see the other one. You can see on the CT scan above it does correlate, but I think a radiologist may well say, because that isn't obviously eating into the bone. It's not obviously a cancerous lesion, and we do get these bone islands, which are reasonably commonly reported. So I think this provides a level of detail on top of the CT scan, which adds to that. And also therapeutically, once we treat that area, we can see it go from, I'd say that's probably sort of orange heat. We can see it go from orange heat, hopefully, to blue with the treatment.
Yeah, and then just a little background on this patient. The PSA at diagnosis was 33. Post-radiation therapy, their PSA was down to 0.1, and then it had recurred at 5.7. And the patient did have positive bone scan. So one other thing I wanted to show you, this is some relatively new data that I just threw in this morning. We've got a partner at BAMP. It's an institution in Grand Rapids, which is actually just where I am. And they've got a really neat new camera there. It's called the U-Explorer, and it's the world's first total body 3D PET scanner, and it has very high sensitivity and remarkably reduces the scan time to as low as 30 seconds. So I don't know how long your scans were. I heard a guy saying it took him 2 days to get his full body scan. typical PSMA scans are, mid-thigh to vertex, and they can take anywhere from, 15 to 50 minutes. But they've been able to really expedite this with this very fancy, expensive camera. So this is another patient with prostate cancer, pre-treatment PSA at 15.6, Gleason of 9. And you can see the patient was imaged with the U Explorer, and the patient has, diffuse PET positive bone and lymph node metastases, and he also has some PSMA PET negative lung metastases. And just wanted to show you, this is the data that they presented just a couple of weeks ago at the Society for Nuclear Medicine, and this is where they're just kind of experimenting with how fast can they run a scan with this and still get good images. So on the right, this is a video of the 300-second acquisition, but you can see the diffuse lesions in bone and lymph nodes. So, the image is very clear at 300 seconds, but even at 120 seconds, 30 seconds, even the 10-second acquisition, you can see the metastases, but they settled on 30 seconds. Apparently there's some, we're not going to go into each metastases, but there were some metastases in the 10-second acquisition that they were unable to view in the 30-second acquisition. But the point here is to show you that the technology continues to improve with what we're able to do with PET-CT, and it's exciting to see that this image quality is attainable at such fast speeds with gallium PSMA-11 with this U Explorer. Okay. Wanted to also update on some of the guidelines. So the guidelines from Society for Nuclear Medicine, European Association of Nuclear Medicine, AUA, so there are all these different governing bodies that publish guidelines for physicians on, appropriate use criteria for PSMA PET. And so these, this is, again, very, very new technology. So they have to update these pretty recently. But following the updated guidelines from NCCN, they've recognized that PSMA PET tracers have increased sensitivity and specificity compared to conventional imaging, basically based on the data that we showed you earlier on, specificity and sensitivity. And so what they've said is that they've now recognized PSMA PET, including PSMA-11 gallium, to be considered as preferred instead of alternative to standard imaging of the bone tissue. So the guidelines that physicians use to determine what their actions are have basically said this is the better way to go. This is in fact superior to conventional imaging. And then this is just on the bottom left here. I've got just a breakdown of based on where you are in your prostate cancer journey at initial staging, localization, and localization of biochemical recurrence of where these different governing bodies describe PSMA PET. And so they're basically saying more accurate in initial staging, an option, and you should perform it in biochemical recurrence. So Joint ENAM, has put out some data saying that we recognize gallium PSMA-11 was used in the VISION trial for the approval of 177 lutetium therapy. And this study, this is a study that led to our approval. Indications for PSMA PET, staging before PSMA-directed ligand therapy. And then there's another guidelines that were just released a couple of months ago. The AUA, American Urological Association, and the Society for Urological Oncology have now added PSMA PET as the preferred imaging method for periodic staging for patients with biochemical recurrence. So this is basically saying that you can stage these patients more than once, more than just initial staging and then a biochemical recurrence. It can be used as periodic staging, and that it is preferred over conventional imaging. And they added PSMA PET as an option for every 6 to 12 months for imaging of patients with non-metastatic castration-resistant prostate cancer. And then they removed the word conventional and replaced it with just imaging annually for patients with metastatic castration-resistant prostate cancer. So basically, the takeaway here is all the guidelines are moving towards PSMA PET as the preferred modality for imaging, initial staging, biochemical recurrence, and periodic monitoring. So next, I'm going to switch gears a little bit and talk about our prostate cancer therapy program. I feel like this is what you guys probably care most about. So we'll get straight to it. So our imaging agent, our therapeutic agent is 177 lutetium DOTA Telix 591, and we kind of just call it Telix 591. And what it is it's a radioimmunoconjugate comprised of an antibody, and it's IgG1, and rosapatimab, and it's linked to lutetium 177, and they're linked together with a chelating agent, DOTA, and that's just pairing the two together. And the way this works is, you guys are familiar with PSMA and what that is. It's a cell surface receptor that's overexpressed on prostate cancer cells, and so this is the therapeutic target. And so what Telix 591 is it's a potential radioimmunotherapy for treatment of prostate cancer, and it's supported by evidence on the conjugate safety and the tumor specificity. And we have already been evaluating this agent for some time. We've done phase 1 and phase 2 studies in approximately 200 patients worldwide. So we've completed phase 1 and phase 2, and we're approaching phase 3 studies. So what's the difference? How is this different from currently approved agents? So the currently approved lutetium therapeutic is a small molecule, and ours is an antibody. So what does that mean? So the antibody is functionally specific for tumor-expressed PSMA, and so it doesn't hit endogenous PSMA. So you may be familiar, this is basically, this figure here on the small molecule is a very common biodistribution of small molecule PSMA agents. So like, gallium PSMA, F18 PSMA, lutetium PSMA, these are all small molecule agents, and there's uptake into the salivary and lacrimal glands, and this can lead to some off-target side effects, including dry eye, dry mouth, and back pain. And so with the small molecule, you don't have that uptake into the salivary and lacrimal glands. So this reduced. So the reason that you don't have those is because it's reduced off-target radiation. So it improves the side effect profile. Also, with an antibody, you have a longer circulation time and tumor retention. So that's very relevant to the treatment. It's cleared in the liver and excreted, allowing for fewer doses. So the currently approved small molecule is rapidly excreted via the urinary tract. About 70% of the activity is lost in 12 hours with that. And so, that dosing regimen is, up to 200 millicuries up to 36 weeks. And so the Telix 591 is 76 millicuries 2 weeks apart. And just to make sure that we're crystal clear on the differences, I put together a little table here on recommended dosage, or the comparison from one to the other. So starting with recommended dosage, with Telix 591, it's just 76 millicuries versus 200 millicuries. 2 doses, so you're dosed, you wait 2 weeks, and you're dosed again, and then your treatment cycle is complete. The 177 lutetium is 4 doses 6 weeks apart, so that's 36 weeks total. Total treatment activity, 152 millicuries versus 800. Excretion via the liver or hepatic clearance versus kidney and renal clearance. And so those are the key differences. Simon, I'd love for you to chime in here on, how does this change, or how does this differential impact clinical care?
I think potentially there's a very large impact on clinical care. I suppose the work that's been done on lutetium PSMA with the positive work done by AAA and Novartis really is fantastic work and is step change work. I suppose I see the work that we're doing and the antibody work as refining that. We talk about precision oncology, and I think the more that we're able to hit the target means less side effects. And that's incredibly important. I mean, I saw remember one of my patients, a lovely man who had the small molecule lutetium PSMA, and very sadly he got this dry mouth, this xerostomia, and he couldn't, he had to have artificial saliva, which is not a very pleasant thing. He had one of his passions was wine, and he had this incredible wine collection that he couldn't drink before he died, and it really impacted on his quality of life. So yes, he lived longer, but he had better quantity, but that quality was really eroded. Now, it's not to say that the antibody will not have side effects. I think like any therapy, it will, and we're honing those down now in the studies that Mary talked about. I think also, and one of the reasons, sorry, that you're getting me a bit out of sync for this talk is I've just come back from bereavement leave because my mother died of leukemia about a month ago. And I've really seen the impact of having to attend hospital. And that 2 versus 6 dose thing is a big thing. You will know this yourself as patients, that as doctors, we're really, I feel that whole medical community, this doctor, and I think a lot of doctors that I've come across, we don't understand the time toxicity for patients, coming up to the hospital, having the treatment. It's a whole day thing. And I think that this bit, particularly as to start with, this will be given in certain centres. It won't be given everywhere. I think these 2 doses are really important, and it's a really big differentiator between them. So I think better precision, potentially better efficacy, which I think is really important. And this time thing is something that's really, really in the front of my mind, where coming to the hospital, it's not an easy thing in the UK. I imagine it's not an easy thing anywhere in the world, and it really impacts on patients. It's a reminder that you're unwell, and I like the fact that that what Aaron said at the beginning, that prostate cancer is 2 words, not a sentence, and I think that's a bit we sometimes forget. And I think this hopefully allows better quality of life and makes you less impacted in the treatment pathway journey than potentially other therapies like chemotherapy, like the other forms of the PSMA. So I like this differentiator a lot.
Thank you, Simon. So next I'm just going to show you a figure that's basically illustrating why we're able to go down to 2 doses versus 6. And the reason is because of the retained radioconjugate in the body. So, so this figure is basically showing how much is in the body over time. And in blue is the 177 lutetium PSMA 617, and in green is the 177 lutetium 591. And you just see within blue, within a few hours, the retained radioconjugate, or the amount of the drug that's still in the body, drops dramatically and stays down, whereas in green here, the amount of agent that stays in the body stays significantly higher for a significant amount of time. In fact, at 2 weeks post-dose, you can still see retention of the agent in the body. And so what I'm showing here is 2 different patients. There's a patient with low tumor burden, or not a lot of cancer in the body, versus high tumor burden. The patient on the right has significant metastases throughout the bones here in the spine. So starting with this low tumor burden patient, so the patient was scanned with Illuccix, and then the patient was dosed with the lutetium antibody Telix 591, and 2 weeks post-dose. So I'm going to bring your attention to some of the metastases here in the pelvis, and you can see 2 weeks later, you can still see the uptake in that tumor site. And what that's indicating is that there's still agent there 2 weeks later. And then same thing, baseline scan, 2 weeks post-dose, you can still see uptake, indicating the agent is still present. And so, what that means is that longer-term retention of Telix 591 in the tumor and the metastases may maximize the cell-killing effect of the 177 lutetium at the cancer sites, and that allows for this optimized dosing. So a little bit on background and safety profile from the phase 1/2 studies. So results from the studies that we've already done that we call ProstACT. So, I mentioned it's been studied in about 200 patients in phase 1 and 2 studies. So basically results are showing that we do have clear evidence of anti-tumor effect and dose response in key measures. And so the key measures were PSA, so PSA and CTC response. CTC is circulating tumor cells, so just how much tumor is still in the body. And we also looked at overall survival. So the figure on the right shows overall survival versus time in months from therapy. And these were late-stage patients. So there were two dosing groups, a low dose and a high dose. And you could see, survival, 50% of the groups, 50% of the patients somewhere, in the low dose group from about 20 months, high dose group at about 30 months of, half the patients. It was highly tolerated with predictable and transient reductions in hematological parameters with subsequent recovery. So they did have some side effects in hematological parameters, but they did recover from those transient reductions. And the fractionated dosing addresses the hematological safety while delivering a target and potent radiation dose to the metastatic cancer. So, summary of the TLX 591 program, antibody versus small molecule efficacy, promising early survival, overall survival seen in the early phase study, patient comfort. So we did observe a reduced potential for undesirable side effects, like Simon mentioned with the dry eye and xerostomia. The patient-centric regimen, 2 weeks versus 36 weeks. We had an advisory board a couple of months ago. We were asking physicians, what does this mean to you? What does it mean for you to have, 2 treatments versus 6? And I had a physician who said, I feel like this is a trick question. 2 is less than 6. But I was kind of thinking he was going to give me a more profound answer, but it's meaningful and then cost effective. So reduced volume of the 177 lutetium isotope via more targeted doses, incurs less waste and less overall cost. So the program overview. So we, talked about our phase 1/2. We're also looking at our phase 3. So our phase 3 study, we're anticipating starting in Q4 of this year in the US. So this is ongoing ex-US, but we're anticipating having tens of sites in the US. I would be surprised if we do not have at least one site in your area. And, I know you want to know, so I don't have any sites selected yet for this in Southern California. But as soon as we do have a site that opens and we're contracted with, I plan to communicate that with Bill, or Heather will communicate that with Bill and send that information to you all. So what we're trying to do here at Telix is just support every step of the journey here. So, look from initial, so this is kind of the patient journey from, from asymptomatic to symptomatic, from non-metastatic to metastatic. And we have a number of different studies and things that we're doing along the patient journey to have a program that can support you all along every step of this journey. So at the bottom half, at the bottom half of this curve, we have some Telix-sponsored studies. So these are large, multi-site, multi-country clinical studies that Telix supports, including the ProstACT studies. We have a Cupid study in actinium that we're exploring as well. And I didn't get into that today, but I don't have a lot of data that I can show yet on that one. And then above this kind of dotted line, we also have IIT studies. So IIT is investigator-initiated trials. And so this is physicians will come to us and say, hey, I've got an idea on looking at, for instance, some study with your product that we'd like to explore in a new population of patients. So we have a number of those going on as well. So just a little bit of data that I was able to share on the study design on the ProstACT. So this has to disclaim this is a draft study design and it is subject to change. We are still in discussions with the FDA on what the final design will be, but this is our current and working draft. So what we're looking at in the phase 2/3 with ProstACT Global is about 400 patients with metastatic castration-resistant prostate cancer. The patient needs to have a gallium PSMA-11 positive scan, and they have to be progressing on NAD. You are eligible prior taxane eligible if hormone sensitive, in hormone sensitive patients if it's been more than 12 months. So, on previous studies, if you had already had, there was a taxane requirement. We do not have that same taxane requirement. You do not have to have taxanes prior to this. And then the patients are then randomized 2-to-1 on the lutetium 591 versus basically standard of care. And then there's an interim analysis after 100 patients have been treated. And we'll hopefully publish that interim analysis. And then the primary endpoint for the study is progression-free survival. And then we'll have some secondary endpoint analysis on overall survival, quality of life, safety, and biochemical response. And so what we believe to be the advantages of this study include we can use this prior to taxanes. There's less frequent dosing and less overall radiations, less off-target effects. And then there's a crossover arm allowing confirmation of progression. So that's what I've got today. Thank you all so much for joining. I believe we've got some time for questions. And as Bill said, there may be some movement. We may have to get Heather or somebody to help with the microphone. But I really appreciate all your time today. It is a pleasure to get to speak to patients, and I wish you all well.
Yeah, thanks, Mary. Thanks, Mary Ann Simon, for the presentation. Got plenty of clapping here in the audience if you're not able to hear it. Any questions? If you would, please raise your hand. Why don't we start right here?
Hi, I have 2 questions. How often do you recommend that the PSMA get done for someone with metastatic prostate cancer to the bone?
So just to make sure I got the question right, how often would I recommend a PSMA scan for somebody with metastatic cancer?
To the bone.
Yeah, let me go back to the guidelines. Simon, feel free to jump in here, but I'll just go to the guidelines
It
first.
has to be on message with the guidelines, and the guidelines are pretty clear about pre-PSMA directed therapy. I think that will evolve over time. I mean, to be honest, in my own practice, we're pretty much switching over to PET scanning. I find it a better, more accurate technology. Now, there may be limitations of availability. Bizarrely, this is one of the things in the UK that we've probably been doing more commonly than the US for various kind of bizarre regulatory reasons. But I think the US is rapidly catching up with regards to that. So I think we'll see an evolution. I think going forward at the moment, I think it's before PSMA directed radioligand therapy is sort of the guideline approach, which is one that we should follow. But I think that will change quite rapidly over time. Do you think that's reasonable, Mary?
Yeah, and I mean, of course, if you're newly biochemical recurrent, so if you've had low PSAs and then you have a biochemical recurrence from an increased PSA, then that is certainly an appropriate time for a PSMA PET scan. But if the question is how frequently after that should you get it, it's a little bit at the discretion of your physician. But these new AUA guidelines say annually for metastatic castration-resistant prostate cancer. So if it's MCRPC, AUA and SUO would say annually.
Okay, why would it be less if it's metastatic as opposed to non-metastatic?
I'm sorry, I didn't catch the whole question.
Okay, so number 3 says if it's non-metastatic every 6 to 12 months, but if it's metastatic, it's annually. And it seems like it should be reversed. If it's metastatic, that you would have it more frequently.
Yep, so I can send you the full guideline paper, but basically in number 3, they're saying PSMA PET specifically. And in number 4, they're replacing conventional with imaging. So like in 4, you have the option.
Okay.
So they'll say any imaging. So these patients, they may want to do a different type of imaging. They may want to do a bone scan. It depends on the severity of the patient. But in number 3, they're specifically calling out PSMA PET.
I think one of the useful things here, one of the surgeons I work with, who is a very direct Yorkshireman for those people who know that part of the UK, so speaks very bluntly, but he always says guidelines are to guide, not to be prescriptive. That may be different in the US with reimbursement, but I think they are guidelines. So I think with 3 and 4, and I think your point is very well made as to why these differences. And I think I'll speak for Mary here, but I think we probably both shrug our shoulders and say guidelines, because of the very nature, and these are really good guidelines and a huge amount of work goes into them, they take a while to catch up with new novel therapies, imaging, and with clinical practice. I think with 3, I think a lot of that may be PSA determined. So PSA doubling rate is really important in non-metastatic castration-refractory prostate cancer. And so with that, we see an inflection point, probably at PSA doubling around 6 months. So you're going to be imaging more frequently where that's concerned. I think with 4, I think at least annually is pretty abstract in the way it's written. I personally image patients much more frequently than that if I feel it's necessary, depending on, as Mary quite rightly said, the nature of their disease, the disease distribution, the therapy they're on, the chances of that therapy working, and other things that come in with that. If a patient's doing very well, so for instance, have a man who, strangely enough, had one of the first PSMA PET scans about 10 years ago, and it picked up a solitary bone lesion in his vertebrae. Sorry, someone's beeping their horn outside, which you may be able to hear. And he had that irradiated, and his PSA is undetectable. He gets imaged once a year because he's got an unusual, very well-controlled, treated form of metastatic CRPC. So I think it's patient-specific, and I think patients should have some input with regards to that, because I think imaging is, as we're talking about the therapy, imaging can be reassuring for patients. It can cause huge anxiety. So I think, again, we need to just look at what are we trying to achieve with the imaging, where's it going to benefit us, where's it going to help with patient management, where's it going to help therapeutically, where potentially may it help psychologically. So I think those are all important factors. That it's a very personal thing for the patients and their doctor, and different doctors have different approaches. I personally do imaging a lot more frequently than annually, but that's to a degree how my practice has evolved.
Did that
Okay, and
answer your
just
question?
one quick little question. You mentioned your friend Tyler Seibert, and my husband's going to be meeting with him for a second opinion. Do you want us to tell him you said hello?
Yes, please do. To tell him I said hello, and that I will take a picture by some water for him. He's a great runner. I used to be a great runner, and we have a little Twitter club where we post, which patients are very welcome to join, by the way, where we post pictures from around the world. So he's a super person who's just a great opinion, very, very humble, very intelligent, and a super person, I think, to be involved in your husband's care. But yeah, please say hello.
Oh, wow. All right.
Yeah,
Next.
you mentioned running. Totally off topic, but we've been supporting some of these zero prostate cancer run walks. Heather, if you happen to have those dates to share for the local events with Bill, we'd love to see you guys all at those events for those that want to get out for a run walk.
All right, next question.
Okay, I had a question. You mentioned, you used an analogy, black and white TV to color TV. As you know, color TV had analog, digital, now they've got high def. Your agent is excellent, obviously, but it may be dependent somewhat to pick up very small items on the...
I think we may have gotten cut off there on audio. We heard the comparison to digital, analog TV, but then we lost you after that.
Is the light on the microphone green or yellow? Green. Green. Okay, good. Just hold it maybe a little bit closer to your mouth.
Okay.
Can you hear now?
Can you hear me now?
Perfect.
Okay,
good.
Great.
Yes, sir. Thank you.
With color TV, there was analog, digital, and now there's high definition. And I wonder if you feel that having a PET CT that is the latest generation would actually allow you to pick up smaller lesions and start therapy sooner for patients that have biochemical recurrence after prostatectomy.
That's a fantastic question, and I think I'm eager to hear how Simon answers this. But I would first bring you to this Explorer. I think certainly the answer is the better the instrument, the better the detection. And we are supporting some investigator-initiated studies where we're exploring, micrometastatic disease and disease at extremely low PSAs and extremely small tumor sizes to validate that. So, intuitively, that's our idea that, the better instrument, better results. But I don't have published data to support it yet. However, I am in the process of attempting to collect that data. Simon, what do you think on that?
Well, I think it's a super question, and I gave you a very sort of big picture, excuse the pun, sort of view of it, but it's kind of how I see it. I mean, patients often want to look at their images. Sometimes they don't, but often they do. And bone scans are super hard to interpret, to show. This is the images that Mary's showing here. I'm stunned by the quality, and also they come across so well in the presentation. I hope you can see them as well as I can see them here. So I think you're absolutely right. We will, as the TB comparison is a really good one, the point you make, and it will improve. So I think we're still on that learning curve. But as you can see by these images from Banff, they're pretty. I think they're easy to see for a non-radiologist like myself. I hope they're relatively easy to interpret for patients. Certainly much easier than bone scans. So the second part of your question about biochemical relapse, I think is an interesting one in terms of, and I think one has to be careful about when one acquires new knowledge about how one uses it in a responsible way. And I think we're doing that. I believe we're doing that at Telix. I think what I hope we'll get to a situation where one can pick up lesions very early, and one can treat them either as Tyler does with stereotactic radiation, or with giving therapies earlier with better results. And I think when we see the results of some of the studies, we see marginal significant gains. What we want to do is see really meaningful gains for patients. So I think that knowledge is powerful, and one has to be careful about how that impacts on people. But I got to go back to my mum, because she had acute leukemia, and one doesn't have imaging for that because it's a blood-borne disease. But I was saying to the doctors looking after her, and it's a hard looking after an oncologist's mother, I was saying, could she have a bone marrow just to see what's going on? And, I don't really want to expose my mother to a bone marrow biopsy unless it's absolutely necessary. And they said, but it's going to be a good result. Why should we bother? And I was like, for mum and my sister and myself, getting a good result is really important. And it will provide us with reassurance that we don't get just from a blood test. So I think that's how we should look on the scans, as a way of reassurance, but very much taking into account patient and their relatives' views where that's concerned.
All right, let's go on to the next question here.
I have a question on your studies that you did for your showing the authorities the sensitivity or whatever of your PSMA. Did you do any comparisons with? I'll use a brand name because the one I can remember is Axiom or Pylorify. Thank you.
Yeah, so there aren't great head-to-head studies on Pylorify. I mean, Axiom. Hey, I don't have slides in front of me, but PSMA, any PSMA PET is going to be superior to Axiom. Now, if you're looking at gallium PSMA 11 versus DCF-PYL or Pylorify, the differences are going to be subtle. So, they're very similar agents. They have a nearly identical biodistribution. There are some differences in the isotopes themselves, and by that I mean the difference between fluorine-18 and gallium-68. So there are some subtle differences there on the physics of those isotopes, but overall, clinically, a PSMA scan is going to give you the same clinical output typically.
Next question. Who else here? Let's go right up to this gentleman here in the reddish shirt.
Howdy. I got a couple questions. You can bear with me. One is I've had 3 PET scans, at UCSD, and I was undetectable about 4 years ago, and now I'm over 3. And do they use the PSMA 11 there, do you know?
Heather's shaking her head. Heather is your local account manager for Telix in the area, and she has more information on who's doing what in the area. But I don't know. I know that last year we were able to provide a list of physicians who are using this, a short list, and so I'm sure that Heather could provide that as well.
Great, I'll talk to her after the meeting, because it's been undetectable, and I've had 3, and the number's going up. The other question, if I understood it correctly, people can only use this after they've tried hormone therapy and they're hormone resistant. Is that correct?
You're talking about our
the
therapeutic
treatment
trial?
Yes, thank you.
Let's see. So the patient, you have to be progressing on NAADs.
And is that because it still hasn't been put out available to the general public? If when it's proven through, is stage 3 the last before it's released?
Yeah, so this was the population that was selected. As with all of our agents, we test in a certain population, and then we have additional studies for approval in additional populations. But this is a study designed for this study. It won't always reflect the population that the drug will be indicated for once approved, assuming that it is approved. We may or may not have to run additional studies on additional populations for approval in those populations.
Yeah, I'm coming from a patient's side. There's definitely side effects with the hormone therapy, and it looks like this could replace treatment without having those kind of side effects. That's why I asked the question. Thank you.
Yeah, no, I understand, and I just can't say what the FDA will ultimately allow us on the label once it's approved. Simon looks like he has some comments here.
Yeah, I think it's a super question. I think as a medical community, we've failed patients with androgen deprivation therapy. I don't think we've taken the side effects seriously enough, and I'm sorry that you're clearly suffering like many men are. I think I have seen a step change recently in the community, and I played a very small part in that. And there are studies now looking at without androgen deprivation therapy. There's a positive study from Pfizer Astellas called EMBARK, which is going to be presented, I presume, maybe at the European meeting later this year, but the top line data is positive. This isn't looking at PSMA targeting, but it's looking at drug enzalutamide on its own versus androgen deprivation therapy plus enzalutamide versus androgen deprivation therapy alone. And that's a positive study for enzalutamide alone to a degree. And I think may well prove to be a step change in where this is concerned. So I think I hear what you're saying. I'm super sympathetic to it. I think those side effects are, and as I know the company are, but I think we have to prove efficacy and safety in this patient population first. Then I think we'll be definitely looking to move earlier and to treat patients who are suffering and to try and avoid androgen deprivation therapy. A study that I'm involved with that we've just got approved from Janssen is called Freedom or Libertas, and the big thing about that is freedom from androgen deprivation therapy. So I think we hear what you're saying, and we're mindful of it, and I think certainly if we see positive nature with regards to this, I think the bit we have to also be concerned about and mindful of is how well the drug works, but also the side effects. So we need to prove the safety as well as the efficacy first. Otherwise, we might be exposing you to harm, and I think that clearly is not the right thing. But very much your point is very well made.
Who else has a question today? Anyone else? Larry?
I'm a little off the subject in this question that I'm going to ask, but what I'm curious about is over in Europe and in England, what do you do with a patient that does not have PSMA expression, which is the case for a friend of mine? What imaging modalities do you use?
Gosh, what a super question. And I said to Mary, these slides are a bit complicated. So this is a very knowledgeable audience. I'm not sure I have a super answer for you, to be honest. I think, first of all, it's a pretty rare situation. So I don't know if you know if they secrete PSA, because sometimes the two go together. I think then you can look at different imaging modalities. I think sometimes we use the PET scan that I grew up with, which is a radio-labeled glucose, and we know that this isn't particularly good for conventional prostate cancer, where PSMA is a much better targeting image, but that can be better for other different cancers. I'd probably revert to a conventional CT scan. I'm not sure if I'd do a bone scan as well. I'd probably start with a CT scan and then maybe do a glucose-labeled PET scan. But I'd be interested to know whether they secrete PSA or not. If they're non-PSA secreting, which commonly goes with non-PSMA positivity and is rare, then usually those patients usually we're better going to more to different types of imaging, like the conventional CT scan as a starting point.
What do you think of Axemin? It seems to have a different chemical mechanism than the ligands. Could one go to that, Axemin?
I don't know enough about it. I don't know if Mary does. It's not something not an area I have any expertise in.
Yeah, I don't have enough expertise on Axemin to give you really a super intelligent answer here. I would defer to his physician for his unique case.
Yeah, so I should have said that. It's really important to not comment on individual cases when one doesn't have all the information. I think if I had a patient with non-PSA secreting and had a PSMA scan that was negative, that's what I would do. But clearly, I hope your friend finds the right expertise to guide them.
And we're certainly lucky that there's multiple mechanisms for the imaging that goes on. I know for me, myself, I was part of the UCSD clinical trial a few years ago where they just had a no contrast agent added and did a MP, MSI, MRI, I think they called it at the time, and that picked up my lymph nodes that did not appear on the CAT scan. Yeah, why don't we give the microphone to Heather for a little bit to give us some comments. Oh, no.
Okay, so you guys are interested in who is doing, obviously there's a couple different agents on the market, and in the San Diego market, everybody is doing Illuccix, gallium PSMA 11, excluding UCSD. Unfortunately, that's where I came from. I ran the whole program and came from there. So unfortunately, they're not using it as of now. And Sharp isn't currently, but will be soon. All the other imaging centers in the area are using Illuccix. And I can expand on that if you're curious. I can give you a list, but that's the big picture.
Any more questions?
Thank you.
Let's go to the lady in the front row here.
This question is going to show how new and uninformed I am. But my husband's PSMA PET done at Kaiser showed no metastases. The word from the oncologist is that the metastases goes dormant he'd been on hormone therapy at that time about 4 or 5 months. He's now been on about 18 months. His PSA is completely negligible, and also the testosterone level can't be measured, it's so low. But on the other hand, what is this about the cancer just going dormant and doesn't show up on PSMA? And it leads to confusion about how to treat and where to go from here.
Yeah, Mary, do you want to comment on that?
I have a comment, but I'd like to let Simon go first.
Oh, okay.
Mary I'm supposed to be the gentleman here, but Mary really has all the manners and the presentations. I'm happy to comment. I think I'll probably comment in a more, as I said, one should try not to comment about individual cases. So first of all, to say what super support your husband must have. You coming to a lecture on a Saturday morning, and you often the people who say I'm not informed, this is a basic question, have the really pertinent questions that are, which this one is. So your question's very well made, and I'll answer it in a more generic way. I think dormant maybe it's quite a loaded word. I would say a very good response, which is shown with the PET scan and on PSA itself. What we know is patients developing an undetectable PSA, and I can blow my own trumpet and once again here by saying we just published a paper on this, are the patients who often do best. So I think it sounds as if there's a very good response, and that's why it's not being detected on the PSA. These are good things. I think it's difficult to know what the future holds, and for some patients they will do very, very well, and their disease will be controlled for a meaningful period of time, and by that I mean several years. But I wouldn't want to comment on individual cases, and I sort of am despite saying that. So I think I would say a very good response, and therefore there's no activity to be seen on the PET scan. Coupled with an undetectable PSA, that's very good news. I don't know if that answers your question particularly. I hope it sort of provides a bit of clarity that the PET scan is looking at cancer activity, which is reflected by PSMA expression, and that not being present shows a very good response to the treatment.
I guess a further question would be, the hormone therapy has brought quite a few side effects that we don't like. So I wondered if one needs to stay on the hormone therapy to keep things completely inactive.
So you'll get me into trouble with Mary and probably the regulatory authorities. It's a question for your oncologist. I think sometimes as a generic point, we're slow to stop therapy that's working. So I think it's a really good question to ask your oncologist. And I think what I would say is clearly things are going well. There is reassurance for us with regards to that. Do we need to be on this treatment? If so, why? But I think it's very hard to comment without all the details, and I may be doing you and your husband a disservice. But I think to ask why is something that I think most reasonable doctors will be very comfortable in answering, and you're in a good place to ask where there's a good response.
Did you say that he did or did not have metastases already?
Well, he was only examined with CT scans, and there was some peritoneal lymph nodes, borderline enlarged lymph nodes in the peritoneum. So I guess that's metastases. A little questionable about bone in the right hip. Little question. And we never had that further examined.
And if I could ask, did your husband have radiation treatment as well?
No radiation. That was suggested, well, it was never by his oncologist, but that was the next program, if that would be beneficial. That's our question, exactly.
I certainly don't have expertise on his particular case, and Jean, jump in here as well, but my understanding is that it's very frequently that ADT is prescribed along with radiation treatment with a certain time frame type of thing, and that's a little bit more the standard of treatment to do both together. However, your husband has his own particular situation that the decision might have been made different, or suggestion might have been made differently.
You can combine that with the, say, the radiation.
Almost every other treatment.
Okay.
Yeah.
All right, thank you.
Yeah. Next question. Do we have any more questions in the audience today? All right, then why don't we wrap up the meeting here. Thank you very much to everyone who attended today. And thank you very much for your time, both Mary and Simon. We certainly appreciate the work that you've been doing, and we look forward to positive completion of the phase 3 trial and hearing when we can move forward here locally.
Absolutely.
Yeah, thank you very much.
Thank you, everybody, for your time.
Thanks, everyone.
All right, thanks, everyone. Bye-bye.
Thanks, Mary. Thank you. Bye now.
Bye, Simon.
Thanks, Simon.